Malignant hypertension is a severe, rapidly progressing hypertension which is a medical emergency with a systolic blood pressure greater than 200 and a diastolic greater than 130. The patient usually experiences signs and symptoms of headache, blurred vision, and dyspnea. The arthrectomy is different in that an instrument called the turbohawk can be used to scrape out the plaque and remove it. Another instrument called the rotoblade spins the plaque into small particles to remove. The interventional cardiologist makes decisions on what procedure to do based on the amount and type of plaque that he finds. This was all taken out of one patient's lower extremity, obviously impairing blood flow and perfusion. So now we're going to discuss how hypertension can lead to impaired perfusion. We've already learned how atherosclerosis increases peripheral vascular resistance by narrowing the lumens of the arteries. An understandable analogy of this is when you put your thumb over the opening of a water hose to increase the water pressure. Basically, you are narrowing the lumen, which increases the pressure. And the same thing happens when our arteries are narrowed by plaque. In addition, there are several physiological mechanisms in the body that serve to maintain our blood pressure within normal limits. And any alteration or disease process affecting these mechanisms can lead to hypertension. Our objectives are listed, and if you're using the Cornell format, I've listed that also. The definition of hypertension is a systolic blood pressure greater than 140 millimeters of mercury and a diastolic pressure greater than 90, based on the average of 2 or more accurate blood pressure measurements taken during 2 or more contacts with a healthcare provider. This is a chart showing what's considered prehypertension, stage 1 hypertension, and stage 2 hypertension. The current parameters are much lower than previously established, with the desired blood pressure now being less than 120 systolic and the diagnosis of hypertension starting at 140 systolic. About 1/3 of the U.S. population has hypertension, and of this amount, 90 to 95% have what is classified as primary or essential hypertension. This type develops gradually over many years with no identifiable cause. The second category is secondary hypertension, which is tied to a disease process. Risk factors for developing primary hypertension can include family history, African American ethnicity, hyperlipids, smoking, age, being postmenopausal, overweight, sedentary, excessive alcohol use, and excessive stress, low levels of potassium, calcium, or magnesium. Although all these variables are associated with hypertension, in primary or essential hypertension, the specific cause is still said to be undetermined. Look over this list to see how many of these risk factors are modifiable and which are not modifiable, because many of the risk factors are modifiable and can be altered or changed or improved by lifestyle modifications. Secondary hypertension is caused by either a disease process or a medication. The most common disease process is renal artery stenosis, which is treatable with dilation and stenting of the stenosed artery through an angioplasty. There is also adrenal-mediated hypertension that is caused by excessive secretions of aldosterone, cortisol, and catecholamines. All of these can lead to an increasing blood pressure. The main drug that can cause hypertension is oral contraceptives containing estrogen, and this is the most common cause of secondary hypertension in women. This slide shows examples of secondary hypertension, chronic renal disease, Cushing's syndrome, hyperaldosteronism, and the pheochromocytoma tumor. Malignant hypertension can be caused by this type of tumor on the adrenal gland. The tumor secretes elevated levels of catecholamines, which include epinephrine and norepinephrine, which cause hypertension. The treatment for this is to remove the tumor. Remember that the primary variables of perfusion include stroke volume, heart rate, cardiac output, and peripheral vascular resistance, which is directly related to the size of the arterial lumen. The body has mechanisms to affect each of these in order to maintain an adequate blood pressure for organ function, and problems in any of these areas can result in a sustained hypertension. The main factors that influence the development of hypertension are increased sympathetic nervous system activity, increased reabsorption of sodium chloride in water by the kidneys, increased activity of the renin-angiotensin system, decreased vasodilation, and insulin resistance. There are baroreceptors in the carotid sinus, the aorta, and the left ventricle that sense blood flow, and through the sympathetic nervous system make changes in heart rate and peripheral vascular resistance. There are two distinct neural systems which are known as the alpha adrenergic and beta adrenergic systems. Alpha 1 affecting the peripheral vascular resistance, and the beta 1 affecting the heart rate and contractility. The alpha adrenergic neurotransmitters and receptor systems affect blood vessels by causing them to constrict, whereas the beta adrenergic system affects both the heart and the blood vessels. The beta adrenergic activity leads to increased heart pumping action or an increased heart rate, as well as vasodilation of blood vessels. So if our patient is taking a beta blocker, then we are inhibiting the heart rate and inhibiting the contractility. And also with the beta 2 receptors, we are inhibiting or blocking the vasodilation that would take place. The kidneys also sense blood flow and make changes in the fluid volume by either saving or excreting fluids, whichever is needed. Blood pressure is proportional to blood volume in that the greater the blood volume is, the higher the blood pressure will be. So one of the main functions of the kidneys is to maintain proper blood pressure through reabsorbing water and electrolytes or expelling them as urine. A medication that is used to lower blood pressure is Lasix, and it does so by eliminating blood volume. The second picture shows the pathway of renal artery stenosis, which results in the condition of secondary hypertension. You saw on the previous slide that the enzyme ACE converted angiotensin 1 to angiotensin 2. Well, we can inhibit this action by ACE inhibitors in order to decrease blood pressure. This slide shows where the ACE inhibitors and the ARBs, also called the angiotensin receptor blockers, inhibit the pathway toward increasing blood pressure. Remember also that the ACE inhibitors end with the suffix pril, such as benazepril or lotensin, captopril or capotin, enalapril, which is also called Vasotec, lisinopril, which is Prenavil, and quinapril, which is Acupril. So those are all of the prils or the ACE inhibitors that are normally given. The ARBs end with the suffix sartan, such as irbesartan, losartan, olmesartan, and valsartan. And The generic names of these are Avapro, Cozar, Benicar, and Diaven. The last mechanism that we'll talk about is insulin resistance. When the body doesn't respond normally to insulin, the pancreas produces more insulin to keep the blood glucose under control. This compensatory rise in insulin damages the lining of the arteries because insulin tends to make arteries more attractive to the white blood cells that cause inflammation. And then the inflammation created by white cells adhering to the arterial walls makes the arteries less pliable, and this loss of elasticity increases the blood pressure as well. We need to be aware that high blood pressure can become a hypertensive emergency. By definition, a hypertensive emergency would be when the blood pressure is greater than 180 systolic or 120 diastolic. It must be lowered immediately to prevent organ damage. Hypertensive urgency is when the blood pressure is very high, but there is no evidence of immediate or progressive damage to the targeted organs. Malignant hypertension is a severe, rapidly progressing hypertension, which is a medical emergency, usually with a systolic blood pressure greater than 200 and a diastolic greater than 130. The patient usually experiences signs and symptoms of headache, blurred vision, and dyspnea. Interventions or goals for malignant hypertension or a hypertensive crisis is to reduce the blood pressure by at least 25% in the first hour, then reduce it to 160/100 over the next 6 hours, then a gradual reduction back to normal over a period of days. Exceptions are if it is caused by an ischemic stroke or by an aortic dissection or any other life-threatening situation. Medications for a hypertensive crisis will include IV medications, sodium nitroprusside, which is also called nipride, which is a potent vasodilator, which will be titrated as a continuous IV drip. Nitroglycerin is also infused in the same way and is slightly less potent than nipride. With titration of vasoactive drugs, an arterial line will need to be placed in the radial artery to constantly monitor the blood pressure. The nicardipine or cardine, a calcium channel blocker, and the enalapril or Vasotec are usually given as IV injections every so many hours. Manifestations of hypertension or signs and symptoms are usually not seen until damage has occurred to organs. And the organs most negatively affected by hypertension are the heart, causing congestive heart failure or an acute MI, the brain, resulting in confusion, headache, stroke, or memory loss, the kidneys. Hypertension causes 25,000 new cases of kidney failure in the United States every year. The eyes, causing retinopathy, and the reproductive system, causing erectile dysfunction. Symptoms are usually severe because they are seen as late-stage signs and symptoms. Patient assessment must include a thorough health history to include the presence of possible risk factors such as age, race, remembering that even being an African American, particularly a male, is considered a risk factor, dietary habits such as high sodium intake, obesity, sedentary lifestyle, alcohol abuse, insulin resistance, and high stress levels. Laboratory tests such as urinalysis, blood chemistry, cholesterol levels will also need to be done as well as a 12-lead EKG. White coat hypertension, more commonly known as white coat syndrome, is where a patient exhibits elevated blood pressure in a clinical setting but not in other settings. And it is believed that that is due to the anxiety some people experience during a clinical visit. So the patient needs to be taught to take their blood pressure at home or work over several consecutive times to determine what their accurate blood pressure would be. Many times, lifestyle modifications alone can lower blood pressure. Losing weight, moderate drinking of alcohol, which is defined as having up to 1 drink per day for women and up to 2 drinks per day for men, limiting sodium of up to 2,300 milligrams per day. And here's just an FYI, there are 2,140 milligrams of sodium in 1 package of McDonald's spicy buffalo sauce. Also, there are 780 milligrams in their creamy ranch sauce. So there's a lot of hidden sodium. Adults must be engaged in moderate intensity physical activity for 2 hours and 30 minutes every week. Such activity will also help to reduce blood pressure. The DASH diet is specific to hypertension and is called the dietary approach to stop hypertension. I put on your blackboard a paper that fully discusses what the DASH diet goes over, so I would like you to look at that separately. There is a standard DASH diet where you can consume up to 2,300 milligrams of sodium a day. And then there is a lower sodium DASH diet where a patient is to consume only 1,500 milligrams of sodium a day. The lower sodium version of the diet matches the recommendations to reduce sodium to this 1,500 level if the patient is over 51, black, has hypertension, diabetes, or chronic kidney disease. And the American Heart Association actually recommends this 1,500 milligrams as an upper limit for all adults. The most common initial medication treatments are a thiazide diuretic, ACE inhibitor, beta blocker, or a calcium channel blocker. Low doses are initiated and the medication dosage is increased gradually if blood pressure does not reach the targeted goal. Additional medications are added if needed, and multiple medications may be needed to control blood pressure. Lifestyle changes should be initiated and maintained as well throughout treatment to control the blood pressure. This slide explains the various categories of medications for hypertension. First, there are the diuretics that decrease the plasma and extracellular fluid volumes with the result of decreasing the preload, decreasing the cardiac output, and decreasing the total peripheral resistance, with the overall effect of decreasing the workload of the heart and decreasing the blood pressure. Then there are the centrally acting alpha-2 receptor agonists. These stimulate the alpha-2 adrenergic receptors in the brain, which leads to a decreased sympathetic outflow from the central nervous system, resulting in a reduction of norepinephrine production. Stimulation of the alpha-2 adrenergic receptors reduces renin activity in the kidneys, which results in decreased blood pressure. The peripherally acting alpha-1 receptor antagonists are for the treatment of hypertension, the relief of symptoms of benign prostatic hypertrophy, the management of severe heart failure when used with the cardiac glycosides and diuretics. And then number 4, it's the beta blockers. They reduce blood pressure by reducing the heart rate through the beta-1 blockade. They cause a reduced secretion of renin. Long-term use causes reduced peripheral vascular resistance. And some examples are propranolol, atenolol, and metoprolol. There are some dual action alpha-1 and beta blockers, or beta receptor blockers. These block the alpha-1 adrenergic receptors, reduction of the heart rate through the beta-1 receptor blockade. Which results in vasodilation through the alpha-1 receptor blockade. And examples of these would be labetalol or carvedilol. Then we have our vasodilators. They directly relax the arterioles and or venous smooth muscles. The result is a decreased systemic vascular response, decreased afterload, and peripheral vasodilation. The nipride and nitroglycerin would be examples of these. Number 7, there are the ACE inhibitors. Inhibit angiotensin converting enzyme, which is responsible for converting angiotensin 1 through the action of renin to angiotensin 2. And by inhibiting angiotensin 2, vasoconstriction is inhibited, the production of aldosterone is inhibited, and the end result is decreased blood volume, decreased preload, and decreased blood pressure. The angiotensin 2 receptor blockers allow angiotensin 1 to be converted to angiotensin 2, but they block the receptors that receive angiotensin 2, which in turn blocks the vasoconstriction and blocks the release of aldosterone. The last one is the calcium channel blockers. These cause smooth muscle relaxation by blocking the binding of calcium to its receptors, preventing muscle contraction. This causes decreased peripheral smooth muscle tone and decreased systemic vascular resistance, which leads to a reduction in blood pressure. Last thought is for the importance of lifestyle modifications to enjoy life and reduce stress.